Hello and welcome to Pulmonology Read Aloud. This is Dr. Anshumaneja Arora, and today I'm going to present a read aloud of this latest article from Lung India, which is a consensus statement on the adult pneumococcal vaccination, specifically in the post COVID era. This was just published on 28 June 2024. And before I begin my read aloud, a huge shout out to one of the key authors in this publication, Dr. Abhijit. Dr. Abhijit Khandelwal is a very good friend. So, congratulations, Abhijit, for this lovely paper. And today we're going to read it aloud and understand it. So, let's get started. So, what is this NAP EXPO panel, or what are these consensus statement or guidelines or recommendation? So, basically, NAP stands for Nation Against Pneumococcal Infections. So, this is a group that was convened as a part of an expert panel group. So, this is NAP EXPO is Nation Against Pneumococcal Infection Expert Panel Opinion. So, this is a review of literature and a deliberation amongst 23 experts who included adult pulmonologists, pediatricians, microbiologists, epidemiologists to understand what is the implication of pneumococcal vaccine now in our country and what we should be doing about it. So, if you are short in time, I want to start it the other way around this time, and I'm going to give you a summary of what this recommendation stands for, and then we're just going to pick individual points and understand why that recommendation was made. So, this is not a Delphi consensus statement. So, the methodology of this consensus recommendation is not that strong. However, they did try to look at all the available literature and that decided what they were recommending in the statement. And there was a moderator who deliberated the whole thing, every point, and every panelist or expert got to speak on that. And then a consensus was reached. So, if you look at the summary, they give us five scenarios mainly in patients whom they should be vaccinated for pneumococcal infection. Number one, all healthy individuals. All healthy individuals above the age of 60 years, when they come into you, you should tell them you should receive a pneumococcal vaccine. Firstly. Two, all COPD patients, irrespective of the severity, should receive a pneumococcal vaccination. Three, in asthma, they did not recommend all asthmatics, but they did recommend all high risk asthma patients. So, those who keep getting exacerbations, who have severe asthma, such patients must receive pneumococcal vaccination. Number four, post COVID cases who have lung fibrosis, who have lung damage, similar to the lines of post TB fibrosis. So, if a patient had severe COVID and has any aftermaths of the COVID or complications, he should be vaccinated. And number five, all diabetics, irrespective of their diabetes control, must receive pneumococcal vaccination. So these are the five major criteria, five major categories which the guideline or which the recommendations suggest should be vaccinated. Then there's a group where you can offer vaccine, and this is something which is new from what it was in the previous statements and previous guidelines. So this expert panel recommends that all smokers, whether they are current smokers or they are passive smokers, must be educated and offered the vaccine regardless of their age and regardless of their health condition. So, this is something that we can start involving more and more in our practice because counseling is a very important part. So, anyone who comes to you and smokes, whether significant active or significant passive, we must tell them that see, pneumococcal vaccines are available. You may be at increased risk of pneumococcal infections. So, this also suggests that you can go ahead and take the vaccination. So, this was the summary of what the recommendations speak on. Now, let's come and understand what was the backbone of this. So this is an epidemiological slide, but epidemiology may be sometimes really too much for us to understand. But I want to bring home the point through this that pneumococcal pneumonia is very much around us. So if you look at the community acquired pneumonia burden in India, it's estimated that 30 to 40% people who have a CAP will have pneumococcal pneumonia or streptococcus pneumoniae as the causative agent. And if you look at all the bacterial pneumonias, then 70 to 80% of those cases will actually be the streptococcus pneumoniae infection. It is also one of the most frequent secondary complications of viral pneumonia. So, post viral pneumonia, suspect streptococcus pneumonia. Hospitalization, again, 10 to 30% is pneumococcal. So, if there are 10 patients, you expect that at least 3 patients of them they will be having a pneumococcal pneumonia related hospitalization amongst the caps. And in elderly, it goes even higher to almost 70% elderly may require hospitalization because of pneumococcal pneumonia. 10% may become complicated. They may also have meningitis. They may have severe sepsis. And if you look at the severe cap mortality is 47% amongst various studies. So 47%, almost half of the people who have severe cap will die despite all our antibiotics and efforts, which is a huge, huge figure. And that's exactly why we must understand that counseling our patients and giving pneumococcal vaccine is a priority and not an option. These are the current guidelines, and this beautiful table, I think, captures the essence of this recommendation. And this is where they have compiled the various guidelines currently available for pneumococcal vaccine, the CDC guideline, the ICS guidelines, the RSSDI consensus statement, Geriatric Society of India guidelines, and the Indian Society of Nephrology guidelines. So, this is where they have summarized. We look at them individually, but what I want to press upon here is that the Indian Society of Nephrology in 2016 recommended that all patients with CKD must be vaccinated with the pneumococcal vaccine as early as possible. And this is being done from nephrologists all across the country. The first time the patient comes to them and they diagnose CKD, they vaccinate for pneumococcal. And this is what we need to start doing for our COPDs, our severe asthmas, or our patients who are smoking. And that is what really comes out of this recommendation. Also, the Geriatric Society of India in 2015 recommended that all individuals who are above 50, you can actually vaccinate them with pneumococcal vaccine. And if they especially have underlying medical conditions like they have heart disease, coronary artery disease, CCF, cardiomyopathy, diabetes, or COPD, we must vaccinate them. And if they're immunocompromised, we must vaccinate them. If they are having organ transplant, definitely we must vaccinate them. So these are certain things which had already certain guidelines which had already incorporated pneumococcal vaccine in a big way, but it hasn't been endorsed much. And here they also mention chronic smokers, also mention people suffering from sleep disorders. So these patients must be vaccinated, and it is by the Geriatric Society of India. So these guidelines have very much given a lot of importance to pneumococcal vaccine. It's just that probably our societies didn't endorse it that much. The RSSDI consensus group in 2022 also spoke on similar lines, where all diabetics should be educated and at least pneumococcal influenza vaccine should be given. People with diabetes, even above 2 to 64 years. So, any diabetic, whether it's a child or an adult, should receive 23-valent pneumococcal vaccine. And when they are above 65, an additional vaccine is necessary. And for people who are above 50 years, a PCV 13 is recommended first and then PPSV 23. And this we'll talk about later. Now, let's have a closer look at the CDC guidelines. CDC guidelines are one of the most popular guidelines on vaccination across the world. So, the CDC 2022 guidelines are most commonly followed. And most of us also know about these and do use it for our day-to-day practice, which says that if your patient is more than 65 years and he does not have a history of vaccination, you will vaccinate him. If he is less than 65, but he's an adult, above 18 years, but less than 65, and he has medical condition. Now, the problem is that we often ignore these medical conditions. So, the medical conditions are chronic heart disease, heart failure, cardiomyopathies, chronic lung disease, where they have included both COPD and asthma. And here they haven't mentioned anything about only severe asthma, the COPD and asthma. Chronic smoker. So this has very well been in the guideline, even by CDC. A chronic smoker, diabetes, all diabetes patients, alcoholics, chronic liver disease, CSF leaks, and cochlear implants. So you have to look at these medical conditions and vaccinate them. And if they are immunocompromised, which again means the immunodeficiency syndromes, HIV, malignancy, nephrotic syndrome, or CKD, chronic renal disease, and that's why all nephrologists vaccinate their CKD patients. Immunosuppressive treatment and drugs. So this would again, in our scenario, our CTD ILD patients on immunosuppressants, organ transplant, asplenia, and sickle cell anemia, etc. They should be vaccinated. So anybody with any medical comorbidity, roughly you can say about, if he's an adult, please vaccinate him. And if he has no other condition, he's healthy and he's 65, you go ahead and vaccinate him. What does Indian Chest Society say? So Indian Chest Society published a guideline in 2019-20, which again, just like CDC recommended that healthy adults 65 above, please vaccinate. Immunocompetent chronic conditions, which include our lung conditions, which include current smokers, do vaccinate. Any adult who has a history of invasive pneumococcal disease. So, for example, I had a patient who is 30 years of age and she had severe pneumococcal pneumonia. She had an empyema, an organized empyema. She had to undergo a thoracotomy and decortication. So now she's had an invasive pneumococcal disease. What do? Now I vaccinate her, even though she's 30 years of age. So, a history of invasive pneumococcal disease, those with cochlear implants, CSF leak, impaired splenic function, or any other hemoglobinopathy. And all immunocompromised individuals, like those with HIV or other immunosuppressive diseases, should be vaccinated. So, it's very much been a part and parcel of the ICS guideline as well, but it's important now to emphasize. So, what is the age of vaccination? The new recommendation, the consensus recommendation that we are referring to here, suggests the age to reduce to 50. So they suggest that the threshold of vaccinating from 65 for a healthy individual should come down to 50. This is a proposition. This was not unanimously accepted amongst the experts because, again, there was no literature to back it up. There was no Indian data substantiating that if you vaccinate above 50, it's beneficial. So they said that if you can't go to 65 or 50, you at least make it 60. So therefore, they recommended lowering this age to 60 and not 65. So this is something that has changed in among the COPD patients. Let's just try and stratify this better. So amongst the COPD patients, they recommend that all COPDs you should go ahead and vaccinate, irrespective of their severity or their coexisting risk factor or their medical condition at the earliest. So, just like CKDs, you also vaccinate the COPDs because they've noticed that there is data which tells us that the frequency of pneumonia is much lower to a rate of 28 cases per 1,000 patient years if they are receiving vaccination. So it protects them. And unvaccinated patients can have as high as 62 cases per 1,000 patient year incidence of pneumonia. So the pneumonia rate will be much less if you vaccinate your patients. And this also applies for patients who are elderly. It also applies for patients with poor lung function. And this also applies for patients with comorbidities. So that is why we must tell them and vaccinate them. And it's also noticed that it also will reduce the risk of hospitalization to from 8 times to 3.8 times. So more than 50% reduction in risk of hospitalization and exacerbations. For asthmatics, if you look at CDC guidelines, they say that asthma is a part of chronic lung disease and you vaccinate them. But if you look at GINA guidelines, they say there's insufficient evidence at the moment to recommend vaccinating all asthmatics. So, what does this consensus statement say? They say if it's a high risk asthmatic, frequent exacerbations, or a diabetic asthmatic, or a hypertensive asthmatic, or a cardiac patient, then you go ahead and vaccinate them. So collectively, they acknowledge that all patients of chronic lung disease, whether it's COPD, asthma, ILD, who are vulnerable to invasive pneumococcal disease, must be vaccinated as soon as possible for a comprehensive care and protection of these patients. Coming to the next part, which is the post-COVID vaccination, which they've really stressed on. So there are still no clear guidelines when a patient should be vaccinated after COVID, but they mentioned that pneumococcal vaccine can be given after 8 weeks of infection, and that should be considered safe. And it should be administered to especially those patients who have post-COVID fibrosis or significant lung damage. They are your prime candidates where you would vaccinate them. For smokers, as I said, it was there in the guidelines, but it's really been emphasized here that whenever your patient is smoking, the risk of having an invasive pneumococcal disease increases by almost 4.1 times. And if he's a passive smoker, then this risk of invasive pneumococcal disease increases 2.5 times compared to non smokers. So, this high risk can be easily diminished by just 14% each year if that patient stops smoking. And it will eventually be the same as the one who's never smoked after 13 years. So, vaccination will offer not only risk reduction now, but it will also neutralize the risk after 13 years. So, hence, all smokers must be counseled for vaccination. Coming to diabetes, all guidelines recommend diabetics to receive pneumococcal vaccine because they are 3 times more likely to contract pneumococcal cap and almost threefold higher risk of hospitalization because of the disease. So, it's important to vaccinate your diabetics. For invasive pneumococcal disease, PPSV23 has a stronger coverage. So, PPSV23 vaccinated group have shown reduced risk of invasive pneumococcal disease, shorter hospitalization, and lesser respiratory failure. So, it is very effective. And some guidelines mention poorly controlled diabetics and all, but they are challenging it and they say all diabetics must be vaccinated. Before I end, it's important to also give you a glimpse of what else is there about pneumococcal vaccine. So, this is an Indian consensus guideline on adult immunization, which was recently again published in association with several societies of India. So, this is a guideline vis-a-vis this expert panel. And if you look closely at this guideline again, they recommend above 50 years. The Indian consensus: pregnant females do not need to be vaccinated. For immunocompromised, again recommended to all. For HIV, recommended to all, even in 18 to 49 years group. Immunodeficiency, CKD dialysis, heart lung disease, CLD alcoholism, diabetes. So they must. This is another group that I really want to speak about, the healthcare professionals, that is us. So, in the healthcare professionals, those at risk should receive PCV 13 followed by PPSV 23 after a year. So, all doctors can receive because we have additional risk. Travelers and in mass gatherings also, it's recommended. So, here they have also given some considerations. So they say if you are above 50, then you should get a 13 followed by 23 a year later. If you're at risk, again you should get 13 followed by 23 a year later. If you are high risk, then also 13 followed by 23 8 weeks later because you're at high risk. The two new vaccines, PCV 15 and 20, they are yet to come, yet to be approved. Once they are there, then it will change to, if you're above 50, one PCV 20 only, or 15 followed by 23 a year later. If you're at risk, then again, just one PCV 20 only lifetime, or 15 followed by 23 a year later. And if you're at high risk, then instead of 1 year wait, you wait for 8 weeks and do the same thing. So now we know the schedule, we know the indications and the recommendations of the panel. So before we close, it's important to just brief ourselves about the vaccine also. So this is taken from the Indian Consensus Guideline document. So what are the vaccines available? Again, would be PPSV, pneumococcal polysaccharide vaccine, PCV, pneumococcal conjugate vaccine, which is 13 valent, 15 valent, and 20 valent. In Europe, in America, 13 is no longer used. They've switched to 15 and 20. We still have 13, 15, and 20 will be coming soon. What is the difference between these 23 and the conjugate vaccines in 13, 15, 20 is that the polysaccharide vaccine, it contains the different polysaccharides from the different serotypes as the antigen. So all the 23 serotypes, the polysaccharides are the antigens. But the conjugate vaccines, they have the polysaccharides for the different serotypes which are attached to an adjuvant or a carrier protein. So they are conjugated. So you can remember it this way, that conjugated vaccine is conjugated to a carrier protein. This is actually CMR 197 carrier protein. So what happens is that only if you're subjecting the polysaccharide, so the immune response in that case will be a T cell independent immune response. But if you are using a carrier, you're conjugating it, the immune response there is a T cell dependent response, which is producing memory B cells also. And this would give you a coverage which is longer. It also reduces the carriage of the bacteria in the respiratory tract. So, PCV or conjugate vaccine helps one reduce the bacterial load also in the tract, and it produces long memory because of the memory B cells. Whereas polysaccharide does the all the serotypes which are in the PPSV23, they protect against invasive pneumococcal infection, and that's why earlier guidelines would mention that if you have to give one dose to a person above 65 who's at risk of invasive disease, you give 23 because it will protect with that. But now they say that 13 followed by 23 is the right way forward. So these are the serotypes, and why this happens, they briefed it, and I just want to bring home this point that anytime in a treatment naive patient who's never received vaccination before, you should start with 13. You should first give 13. If you're planning to give 13 and 23, you give 13 because it will increase the anti-pneumococcal response to subsequent administration of 23 for those serotypes. So 13, giving it first will improve the response to the 23 Vala serotypes because of, again, memory cells, because of the recall and immune enhancement. If suppose you administer PPSV 23 first and then you administer 13, then for those serotypes, actually, it becomes a hypo response. So following the administration of 23, if you give 13, then it will cause a reduced response. So whenever 23 is first administered before 13, and you need to give another serotype, another vaccine, remember that the more 23 you will give, actually, it will not be a boosting of response, it will be a hyper-responsiveness. So this was a very good study which brought this point, Greenberg et al. And so that's why it's justified that 13 first and 23 later. And if at all you have to give a booster dose, if somebody got vaccinated at the age of 18 or 20 and you want to repeat a dose, remember that the second dose must not be within the first 5 years because it will lead to hyper-responsiveness. So there are a few other guidelines also, like the API guidelines, which are not mentioned in the consensus statement we're dealing with, which talk about again more than 19 and more than 50 years age group, again 13 by 23, and the IMA guidelines, which mention one dose uh, for all adults and two doses for at risk adults, which should be 4 weeks apart. So stay tuned for more videos from Pulmonology Read Aloud. Happy reading and thank you for subscribing and sharing.